Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hello there and welcome back. I think we have stopped counting episodes. David Kaufman here with you, my colleague and friend,
Eileen
Ruhoy. So we are going to cover or talk about a really big topic, which is hugely huge for our patients, so-called brain fog. Okay, I'm going to start with a comment about brain fog. I use the term all the time. Our patients use it all the time. Unfortunately, it's kind of like chronic fatigue syndrome. Okay, it allows the medical world to disregard it. Okay, and it's followed that same trajectory of, well, brain fog. We all have brain fog sometimes. Go home and take a rest or exercise. That'll help your brain fog, and it just gets me crazy. Mm-hmm. Brain fog is as real as it can be. All right, and I wish we could change the terminology and call it what it is, which is neuroinflammation. Okay, but we're stuck with brain fog.
Well, I mean, even the word neuroinflammation, I think, is used too much, that it's sort of lost its pizzazz a little bit.
Yep, absolutely.
And I've seen some neurologists go, what is neuroinflammation?
Right.
And so, specifically you can talk about the microglial cells and the glial activation and all that stuff, but then they glaze over because they don't really believe it to begin with. They're just trying to be controversial.
My better term is autoimmune encephalopathy.
I love that term, actually. I do think that it does describe what is likely going on. I think brain fog, I like it. I think it's a good descriptive term to what patients, that their experience, right? It's subjectively what they are experiencing, like they're in a fog. So they don't have mental clarity. They can't think straight. They can't see straight. They can't make decisions. They can't focus on a task. They can't complete a task. They can't follow a conversation. So that's a fog. You're just in a fog.
But important to point out that same patient can sit here with you being the patient and me being the doctor, and I can interview you for 90 minutes and you'll be able to answer every question.
Yeah.
And that's one of the reasons that they get ignored when they go to a physician's office. You need to ask the right questions for the patient, to the patient, in order to clarify what they mean by their brain fog. It doesn't mean they can't have for some patients it does, of course, but for many it doesn't mean they can't have a conversation. It waxes and wanes, peaks and valleys, as we mentioned in a previous episode. And there's some very specific things that they will describe to you. And
it's energy dependent is what I find. I mean, many patients will say, I'm going to crash after this appointment.
Oh, yeah.
So they're able to summon up enough of their, cognitive energy to sort of answer all of my crazy questions. Absolutely. But then they go home and are deep in a fog.
I can see it during the appointment. I had a new patient, a new long COVID patient on Wednesday. And I could see him after about 15 minutes. I started losing him, and I said, "Am I losing you?" And he said, "I'm hanging in there." But there was a huge difference between the first 30 or 40 minutes and then the rest of the meeting.
Which makes me believe that it's truly an energy demand and supply kind of problem, right. And of course that speaks to the mitochondria, so which are burdened by all of the neuroinflammatory activities that are going on.
So just getting to doing some basic history stuff. One of the kinds of questions I find useful to understand when a patient says brain fog, what do you mean by brain fog? Do you have trouble with conversations? Mm-hmm. Do you have word finding problems? That's almost universal, I find. Everybody will say yes to that question, and I'll ask some examples. Mm-hmm. Are you able to read? Can you retain what you're reading? Most of them will say no.
That's the best question I love. Can you retain what you're reading?
Right. So they usually say, I give up after a paragraph. Mm-hmm. Audiobooks even, some of them can't follow. They have to keep rewinding. Can we say rewind these days? It's not a tape anymore, right? Well, whatever. They have to go backwards.
Everything is voice controlled, you're saying? I have to drink my carrot apple juice.
Television or streaming or whatever, same thing. They can watch, but often they will say, well, I got to watch it again tomorrow night because I don't remember anything.
Right. There's also, I think there's also a level of like limbic involvement, right? Because they'll talk about basically anhedonia. They don't really get joy out of anything.
Right.
They talk about feeling dissociated, so they don't have the similar connections to things that used to bring them joy. They feel their emotions are either have too many emotions, like they're labile. Well, I've had patients describe that they cry, at seemingly random things, or those that just have lost their emotions. I've had some sad stories of where patients don't, well, some actually have told me that they no longer feel the connection to their children
Right.
that they had felt, and that, breaks their heart. And so there's a level of dissociative kind of symptoms that they'll give, and like I said, anhedonia. So there's also, it's not just about cognition and cognitive abilities, or even focus and attention for that matter. There's also a limbic involvement, it seems.
Oh, absolutely.
And then even in terms of pain perception, they definitely have allodynia and hyperesthesia. So I think that whatever this brain fog process is, and I agree with you that it's neuroinflammatory, it also heightens pain sensation and pain perception, maybe. So I think that there's so much to brain fog, and we need better research to truly characterize it, so that sometimes I don't even know where to begin when patients' primary complaint is brain fog. Like I start to ask all these questions, of course, but it leads me in different directions sometimes when I'm trying to grapple with what exactly are they experiencing, because to me, the brain fog is, again, what they're experiencing. So I have to try to understand how they're experiencing it compared to the patient I had just seen.
Well, I think for patients, it's one of the scariest kinds of problems in this septad population.
For sure.
You can't see it. It's very difficult to test for. It's hard to share. It's not like, if you have a rash, you can show somebody,
right?
And it immediately conjures up images of, am I getting demented? Do I have Alzheimer's? Will I ever get my mind back? And, when you come down to it, our brain, our consciousness is what makes us human. So it's a terrifying problem.
They're very worried about dementia syndromes. That's a very common question I get, for sure.
Right.
But it's important to understand what they're experiencing in their daily life. And you're right, just like they could sit and have the conversation and answer all of our questions, cognitive testing is often fairly normal, and
Don't
sometimes
even
it's
get me started on the neuropsych cognitive testing. I mean, really, it can be useful, and it does create an objective record. Again, the only reason I would ever send a patient for it is for disability insurance reasons. But I've had so many patients get rejected because the insurance says, well, your neuropsych's normal. And what really happened was the neuropsych tester, the person, just applied the same normative values to my patient as they might to another patient, or another person. So if my patient is a software engineer with an IQ of 135, and they test out now at 100, that's called normal.
I know.
That's not normal for that patient. And they literally get denied their disability.
That happens a lot. Patients will say that I was so high functioning. I was tested when I was young. Right. My IQ was this. And so what looks normal is not normal for me. And that's what's scary to them, right? They've lost this very high level of functioning skills, this very high level of executive function skills. And they don't process things as quickly. It takes them a lot longer to learn something. Yeah. And that's terrifying to them because they've lived their entire lives being exceptional, basically.
Right.
Yeah.
I will have patients tell me it took them a day to write me an email.
Yeah.
So.
Yeah, and it affects their relationship. So, and a common question I'll ask is, has it affected your performance at work?
Right.
And, it's invariably
I
yes.
always ask that too.
And I've actually had some patients who were fired because they could no longer focus on a task.
Sure.
And so, and that, of course, is scary because now they've lost their livelihood, and that brings a whole other set of problems.
One of the silver linings in COVID and the onset of remote working is that for our brain fog patients, many of them have been able to keep their jobs because they work from home and they can parcel out. Yes, they can pace out their brain function. So
and they didn't have to use any of the energy in the commute.
Right. And it's been a huge benefit for patients.
I agree. Although that's seemingly going away now. People are demanding to come back to the office.
I think it's still.
You think it's here to stay?
Still here to stay. Yeah. So let's talk about.
So do you do any kind of? So we talked about neuropsych testing, which obviously is just fails us all. But what kind? Do you do any other testing?
You mean to try to objectively confirm that they have?
Yeah, to sort of see. I mean, I always feel like testing gives me ideas for treatment if I find something positive. What do you do about brain fog?
Well, I have to say the first what I think is that the two major drivers of brain fog in our patients is uncontrolled POTS and small intestine bacterial overgrowth and leaky gut. So I go after that like a blankety blank bulldog. Okay. And I really believe this, and I can tell you example after example. I had a patient this week who finally decided to treat her SIBO and her leaky gut after diagnosing it 6 months ago. And she got on the video and she said, I have my brain back. I can think.
That's amazing.
All of a sudden. And the only intervention was SIBO, antimicrobial treatment and leaky gut treatment.
That is amazing.
Right? And
yeah.
I see that often. But
there's
one
a
was really
strong
dramatic.
connection between the gut and the brain, of course.
And directly, and then all the leaky gut stuff and neuroinflammation and leaky blood-brain barrier.
Mm-hmm.
So I go crazy over SIBO, as my patients know, and over POTS. Because if you don't have a blood flow to your brain, you're going to be foggy. If my blood flow decreases, I'm going to be foggy. Anyone. All right?
Right.
And it's, I don't want to hijack this back into POTS, but the issue isn't what your blood pressure is, it's what you say you feel when you're measuring that blood pressure standing. Okay, so
right.
That's where I start. Actually, I don't start with doing a mini mental test and all that stuff.
You don't bother.
I don't.
Not even to just sort of objectify it at any level.
No.
That's interesting.
It's sloppy.
It's not sloppy.
Well, I mean, I probably should be doing it. It's more that I question them. They give me the answers that confirm in my mind. I totally believe the patient. And then I want to get to work on what I think is causing it. So those are my first two.
Mm-hmm.
I'll always look for infection.
Yeah.
And obviously mast cell activation. It's a septed. It's
right.
It's interesting. In the septed, we have not included brain fog. It's an interesting.
Right. I think brain fog became more reported with long COVID. I think I heard brain fog more from the long COVID patients than I did from the ME/CFS patients.
I don't feel that way at all.
No?
Mm-mm. No, they all have, all the ME patients have brain. ME.
Well, I know they all have it, but that wasn't like a prominent concern that they brought up, at least to me.
Oh, I would get it every single patient. Yeah.
It's interesting.
So it should be, now that I think of it, but I like.
Because it was more the PEM that was the prominent concern. The PEM.
Yeah. Well, PEM is so-called defining symptom, but
right.
But they have all these other symptoms. In brain fog, I maybe have one or two ME/CFS patients who fulfill criteria who don't have brain fog, but they're so rare. Mm-hmm. They almost all have brain fog. And it probably should be part of the septits. Another category.
Let's
but
add it.
Whatever. So I look for the underlying causes. I spend more time doing that than saying, well, I got to prove you have brain fog. I just don't do that.
Yeah, no, I'm not looking
I'll document it.
Yeah.
In my notes, I'll say the patient couldn't finish the sentence or keeps referring to notes or something that shows that I see it.
Right.
But I don't go through the testing.
Yeah, my concern about doing the testing, like I do the MOCA usually, is that, they do well on it. And then I'm sort of negating what they're telling me, like objectively in their chart note. And that worries me for any kind of insurance reason, so sometimes I don't do the standard testing, and it's just really the conversation that I have with them, and I just sort of assess how they're answering. And there is very often sort of a delayed response, and I'll even report like in my examination notes, sort of delayed response, delayed latency of response kind of thing. Speech is halting, right? Totally. Word recall, sometimes they can't think of the word, or they use like what we refer to as paraphasic errors, which is using a different word for another word. And they'll often do that kind of stuff because they can't think of the right word. And then, I'll do like neuroquant, those like volumetric studies.
Right. Okay. So let's keep talking about workup.
Okay.
No, I know. I
thought I was.
No, I mean, other kinds of workup besides the MOCA.
Right. So I do neuroquant studies. I mean, MRIs are always normal. But I do the volumetric studies, which I think will show us something, and often does. Interestingly, people think that you look for, smaller brain atrophy is what people would expect. But interestingly, with a lot of my brain fog patients, I'm finding larger volumes of brain, which is very much consistent with the mast cell activation, right? Because there's just sort of extra inflammatory mediator release in the brain. And so there's a perceived higher volume of some regions compared to other regions. And so to me, that sort of does at least support the idea that there's inflammation and therefore something behind this brain fog experience that they're having.
Right. I don't really do neuroquant much. I find what I would like to do more, I do some, but like to do much more other dynamic scans, the functional scans like SPECT
functional
or
MRIs.
PET.
Yeah.
Well, functional I can't even begin to get, but SPECT or PET
Yeah.
scanning, which can be dramatically abnormal. And I find that can be useful, one, to help the patient understand they're not crazy, and two, that even sometimes can help with insurance to document here's
Absolutely.
an abnormality and we're slowly improving it.
Yeah.
But like you say, MRIs are
Yeah,
not
MRIs
helpful.
are normal.
Not helpful.
But I do find PET scans to be helpful. I regularly see hypometabolism
Right,
on PET scans in
exactly.
patients who have
Patchy hypometabolism.
Right, exactly. So you're right. There isn't a trend of an anatomical region involved. There is patchiness to the hypometabolism. So it's more diffuse, but there seems to be a more consistent involvement of the hippocampal regions. So which does, of course, support their concern of their memories and their word recall and things like that. So I agree. So I think that these things are objective enough to sort of say there's something going on here.
Right.
And then I do a lot of I'm like a child.
First you talk about whiz, and now you talk about doo-doo. Huh?
Did I tell you I was not mature? So I regularly do an autoimmune workup, and looking for evidence of autoimmune disorders that we know, autoimmune disorders are well known to be associated with vasculitis or vasculopathy of sorts. And so I do think that this is about blood flow to the brain. And so I think that there's a vessel involvement, which does speak to your dysautonomia that you treat as well. First and foremost, you treat the dysautonomia for brain fog, because I think that that's something important, right? So back to blood flow, which we talk about a lot, which is that not only does it need appropriate blood flow, but appropriate perfusion. So if there's hypometabolism, it does support that there is lower perfusion. And then if you can prove that there's an autoimmune disorder, then you can extrapolate and say then there's likely some level of vasculopathy that's not allowing for not only appropriate perfusion, but appropriate flow. And then again, with these EDS patients, I'm now regularly finding, it's like I have a hammer and now everything's a nail, so I go looking for the nail, but I'm finding evidence of compression. Just from their misalignment of their anatomy and things that go wrong in their connective tissue. And so that can impair outflow or inflow, which then further compromises cerebral blood flow. And we've already known that ME/CFS patients, because we've done transcranial Doppler studies at Mount Sinai, that ME/CFS patients and CCI patients, of course they're there because they also have CCI, so I should say ME/CFS and CCI patients have suboptimal cerebral blood flow. And so that exists, we already know that. So there's a blood flow issue.
Right. I mean, as we've said over and over in this series, everything's connected. Every single item in the septet can and does cause brain fog, and they can all do it together. They're all, unfortunately, synergistic in the way they work to do that. And to me, therefore, we literally have to go after each piece of that septet very diligently and carefully, and not necessarily even sequentially, but all at the same time.
Right. Right.
Because I think that's the only way you can make a dent in this.
Right. Fortunately, a lot of the treatments overlap.
Exactly.
So it makes it a little bit easier.
But to be clear, SIBO, dysautonomia, mast cell, they all can cause this. Infection, don't even get me started, how the ways infection can do it. Autoimmune, think pandas-like illness. Plus, obviously, the vasculitis that you talk about. So all of these things can cause the brain fog, and it's a key thing to understand.
I agree. And, I'll try to find markers that there is low oxygen perfusion. There's a couple of, but I like to do lumbar punctures when there's prominent brain fog, or when I get for example, a PET scan with hypometabolism or volumetric studies with clear inflammation or an inflammatory response. I will regularly do lumbar punctures, and I fully admit that they are usually normal.
Okay,
but there's been
what do you learn from them? Okay,
but there have been a handful of times when they weren't normal,
Right.
And so I think it's worth doing. I think people are weirdly scared of lumbar punctures.
Yeah, so I guess I understand. I'm not scared of lumbar punctures. I guess my approach would be, I would send them to you if I'm getting nowhere.
Right.
Meaning, let me deal with the low-hanging fruit, which is obvious to all of us, and then, but if you're not getting better, I've missed something. Time to get a needle in your back. But
right.
I don't do it routinely.
Right, and I definitely don't jump to it. It's certainly down on the list after I've done lots of other things. But I really work hard and I think it's not about. It's not about whether I believe the patient or not, and it's not even about whether it's going to change my management, frankly. It's about, I want to prove something. I want to prove about something. We don't know enough about this brain fog concern. We know very little, actually. In fact, a lot of what we're even saying is somewhat theoretical. We would fully admit.
It's all anecdotal.
Right, absolutely. Yeah. So I think one of the reasons why I do as much of a workup as I do is because I'm looking for that needle in the haystack where I go, maybe this is what it's all about. And then we can sort of use that and catapult, further testing that we come up with, or even a research project. So I go looking because I like to try to contribute to the knowledge of these patients, because we just don't know enough. Right. And I always tell patients, like, listen, if there was a magic bullet, then we would all be giving it to you and no one would be sick. Right? So there's so much still left to learn. And I feel like we have these patients in our clinic. And if I have the ability to do a particular test that maybe some of the other docs that are seeing these patients don't, then I'm going to do it, because who knows what I'll find.
No, I agree with you.
So that I know, and maybe I'm sounding a little like
No, I think you're absolutely right.
Revolutionary.
And it's sad and frustrating that so much of what you do and I do does get lost, so to speak. I mean, I've often had this fantasy of, I wish I could just have a full-time scribe type person in my office all the time, or in my telemedicine area, tracking everything so that it doesn't get lost and then can get reported. I mean, the number of times something's come up and I think, God, I want to share this. This is important. Yeah. But then I don't have time. And
I know exactly what you mean.
It's very frustrating.
I know.
So I agree with your goal. Just hard to get there.
Right. And I think brain fog is just one of those diagnoses that are unlike things like small fiber neuropathy or even POTS. I think that there's still a lot of like, what is brain fog conversation I hear amongst other doctors. Like, what does that really mean? Like, as you said at the beginning, everyone's got brain fog sometimes. Just go take a nap, Right. But clearly that's not what this is. And a nap is not going to fix it. But we can't put our hand on it. We can't put our finger on it. There's no hook to hang our hat on.
Right.
And all those things.
No, it's true. It's true.
So so I go looking.
That's why I like the PET scan and SPECT scan
I do
imaging,
too.
because that's actually something you can see. Jared, what's his name? Jared Younger? The guy who's done a lot of low-dose naltrexone.
Jared Younger.
So he's done some brilliant, beautiful work using those types of scans, showing microglial inflammation. He's got some new tracer to show that.
Right.
And then giving them low-dose naltrexone, which we'll come back to, and showing the change, or other agents as well. So that's what we need.
Absolutely.
And it's vindicating in the sense that, yes, there is an anatomical, pathological reason for your brain fog.
That's exactly what we need. We need more of it.
Right.
Yes, I agree. We should do a clinical research project.
Add it to the list.
So how do you treat brain fog?
Well, first I treat everything else.
Right. And let's say the brain fog is still...
Okay, so LDN is still my first go-to drug. Right? It has clear microglial anti-inflammation properties. And it can really help. So LDN, as a one aspect of it being, it can directly help or treat, and indirectly, because it can do all the other things we've talked about that it can do, meaning it can help leaky gut. It can help SIBO and gut motility. It can help mast cell activation. It can help autoimmune. So it's got lots of different effects. I'm trying to think of the non-septate treatments. I do use sometimes stimulants. I'm not crazy about it, but I do it. Ritalin, Adderall. Sometimes it helps. I used a lot of very low-dose Ritalin early on. I used tons of it back in the HIV days. It can be really helpful, but a lot of patients really experience a crash as it wears off.
It's interesting. Do you use any blood thinners?
I do, more and more. I'd like a little more proof because I get nervous about risk. I've had a couple of patients, you just give them 81 milligrams of aspirin and it's hugely effective, helpful, which isn't surprising. As you said earlier, it's all about perfusion. Yeah. And we know that there's sticky, sludgy blood in so many of our patients, both ME/CFS and long COVID. And then when you start looking for the risk for that, you and I put together this clot panel. And when you look for it, it's like, whoa, I'm finding a lot of positives here.
Exactly.
And there's clearly a correlation.
Do you use statins at all?
I love statins. Yes. I don't use them as much as I'd like to because the patients fight me on it.
Right.
They are so, sorry, patient population, so brainwashed by the internet chatter on statins.
Yeah.
Statins are an amazing drug.
I agree with you. I use statins all the time.
They are anti-inflammatory. They heal endothelial dysfunction.
That's how I explain it to them.
Yeah.
And so any patient who wants to fight me on it, I explain what's happening. I always explain, with the burden of inflammation in your brain, the endothelial lining of your vessels is under duress and it's starting to break down. And when the lumen starts to break down, then things love to stick to it, including platelets, who love to stick and aggregate and form clots, and all this stuff sticks. All the mediators from the mast cells stick. So what we need to do is we need to fix the lumen of those of the vessels, and there's no better way to do it than with statins. That's exactly how I describe it.
Yeah. No, I agree. I think statins are amazing.
Yeah. So
they
I
also
actually
help with immune competence. They help with they modulate the immune system.
Yeah.
There's data to show that if a person gets COVID and they're on a statin, they have a greater chance of survival than if they're not on a statin. I mean, over and over and over, we see this.
I know.
With
I think I shared with you my new neuroinflammatory protocol. It's got a statin on it.
Yeah.
Yeah. No, I've been using it actually. It's been very helpful for a lot of patients. Huh?
You want to explain it?
Not yet, because I want more.
More information. Okay.
I want more patients.
All right. So statins, stimulants, LDN, vitamins. All right. I always want to make sure their B12 is where it should be.
Yeah, absolutely.
Where it should be is not normal. It's mid to high normal. Okay. If I get crazy when a patient comes to me with a B12 of 350 and they say, "Oh, my doctor said it's normal." 350 is not normal.
Not normal.
Okay. So B12 and folate. Vitamin D for sure. Same argument. Don't tell me it's 31, so it's okay. That's not okay.
Magnesium is really good at stabilizing the blood vessels. So.
Right. So vitamins.
Vitamin E I love.
Yeah.
Vitamin E has a lot of research, not large studies, but sort of shows, for supportive cognition.
Right.
In fact, early Alzheimer's,
Well, and thiamine too.
Right? Thiamine as well.
Right.
So yeah, vitamins are super important. I agree. Because if we're going to perfuse the blood, it might as well have some vitamins to give to the brain cells, right? So.
Right. Yeah.
As well as oxygen.
Very important. I'm trying to think of what other meds.
So you mean pharmacologics, medications?
Yeah, I guess I'm having trouble thinking of them because to me it's part of the whole.
Yeah, so I do blood thinners.
Stuff too.
I do blood thinners. I do statins because I want to protect the vessels. I do mast cell stabilizers.
Right.
I actually also do things like ginseng and ginkgo, which have a lot of vascular support. So I do that's part of my protocol actually. Right. But there's a lot of research behind those because those plants have been around for a really long time. Of course, there's a lot of research on them because they were used for a lot of different reasons over the decades. And then I also use things like memantine, Namenda, right? Which it stabilizes the NMDA receptors. It's known to be neuroprotective. In fact, we use it for TBIs, for example, and I sort of see this as like almost like a chemical TBI,
right?
Or an acquired TBI as opposed to traumatic. But I guess that's the T. But anyway, so I use a lot of Namenda to stabilize those receptors, which does seem to help the memory. Again, it's if you look it up, it's used for early Alzheimer's, and so people always get nervous that they have Alzheimer's, but I always explain it's used because of its mechanism of action, which is protective over those NMDA receptors, which are concentrated in the hippocampal region, which is where our memory centers are. So, and it's actually been very effective for a lot of patients. They seem to like it. The other thing that I sometimes give is like dopamine replacements, like Cinemet even.
I've used Cinemet.
Yeah, so dopamine sort of seems to enhance their ability to learn, to interact. So I sometimes, and I don't do it regularly. I just sort of, it's like I select which patients, and based on some symptoms and history, I might give some dopamine replacement as well. There's some plants that are dopamine replacements, like Mucuna pruriens, and I tell them about that just because I don't want to have to rely on pharmacologic replacement of dopamine, which, can sometimes not be fun. But there's a lot of different drugs that I pull from trying to sort of clear their fog a little bit. And I just sort of focus in on, again, the health of the vessels, the flow of the blood, the perfusion of the blood, and how the parenchyma is responding to the lack of blood over this time, right? So that's why I want to stabilize the NMDA receptors. I want to stabilize the mast cells because when you're in a hypoxic environment, you have a lot of mast cell release. And so basically that's what the brain is experiencing, is how I see it with brain fog. It's it's sitting in a hypoxic state. And when it sits in a hypoxic state, there's no easier way than to put the cells in cell danger response than being hypoxic, right? If it's not getting the oxygen it needs, then nothing is going to work. The mitochondria are going to shut down. The functioning of the cells in terms of communicating with one another is going to shut down. So they end up just wanting to protect themselves because they're hypoxic, because hypoxia, induces hypoxia-inducible factor. And so that HIF then sets off a whole cascade of events that just causes further inflammation and further activation, I should say, of the microglial cells, which is what neuroinflammation really is about. So I think that's how I sort of sit on that kind of physiology and think about how I can fix that. And there aren't a whole lot of ways in conventional neurology to fix that, frankly. I think that, if there's a stroke patient, for example, which of course is an extreme example of hypoxia, and you have an ischemic event and you have a stroke, there's an area around that stroke that's called the penumbra, which is at risk. And it's just that it's basically in a hypoxic state. And so we, fight to save it. And we use statins, for example. We sometimes vasodilator kind of medication. Certainly managing glucose levels is important. So going back to the metformin, even I sometimes use for these patients.
Yeah, sure.
Also, interestingly, just from my alternative integrative medicine world, apple cider vinegar has the same mechanism of action as metformin does. So for some patients, I might say, take a shot of apple cider vinegar twice a day. So I come up with all kinds of, I sort of tweak plans for patients. I tailor it for a particular patient based on, again, their symptoms, their testing, their history, just to sort of make sure that they get the most effect and the most response without any kind of adverse effects if I can avoid it.
Yeah, I think it's important to emphasize that a little bit like our conversation on small fiber neuropathy. Mm-hmm. There's what do we do to manage the pain, the symptom of small fiber neuropathy, and what do we do to manage the causes of small fiber neuropathy?
Right.
So everything you were just describing, or almost everything, is an effort to manage the pain, so to speak, of brain fog. But I don't think we're ever going to get there unless we 1,000% focus on the causes of that brain fog, mm-hmm. which are all occurring everywhere in the body, mm-hmm. in terms of the septet, and not just I'll fix your SIBO and that's the end, or I'll give you, metoprolol and go home. It's very rigorous, very careful, serial measurements, sequential looking at, excuse me, to see if that benefit that you hope that you may have initially gotten is sustained. Mm-hmm. Often people develop a tolerance to a medicine and the benefit decreases. Mm-hmm. SIBO often recurs. Leaky gut takes forever to heal. And my concern is that all of the neuroinflammatory interventions to try to reduce that are not going to help unless we can stop the things that are causing it.
Right. So the root cause.
Right. And I'm not saying it has to be two separate things, obviously, mm-hmm. but I just don't want to lose sight of that. I don't want people to lose sight of that.
Right. I agree. But I think that sometimes the brain fog sort of presents like somewhere along their journey. Like it wasn't from the very beginning, even though they had all these diagnoses. Right. I think something sort of abruptly invokes the brain fog kind of sensation.
I think that's really true. It's very interesting when you take a history.
Right.
I'll have 3 pages in my notebook of history, and brain fog doesn't pop up till the top of the 3rd page.
Exactly.
So the first 20 years of the history and much
right.
happened. And I think that speaks to exactly what we're saying. It is a cumulative end product of endless insults to the rest of the body.
Right. Right. And so what we also know about any kind of degenerative and progressive process is that the faster and more aggressive that you can treat something, the more recent symptoms have a greater chance of reversing.
Absolutely.
Which is why I'm so aggressive at just sort of treating this brain fog when people tell me about it, when patients tell me about it. And you're right, but treating all the underlying septet diagnoses are just as important, because then it's just going to be on a hamster wheel.
Right.
Yeah,
exactly.
For sure. And I bring them back for brain fog. I bring them back fairly regularly, and I just sort of sometimes if I am doing the MOCA exam, for example, I'll do serial exams. Just to sort of get a sense, and then I'll have a specific set of questions that I ask them with regards to how the brain fog is impacting their daily life, and we'll go through those questions again. So how is it impacting it now? I'll even have them do traction trials, which we sort of talked about with CCI.
Oh, yeah.
Because I always say that the question that I want to try to answer is that if I improve blood flow to the brain by removing any kind of compression that might exist because of, CCI, and this is obviously only for the EDS patient population, of which, most of them are hypermobile at least. I'll see if traction actually helps the brain fog, and I'm actually surprised at how often it does.
Yeah,
and we actually, when we do CCI patients, very often they'll say, "Wow, I have such mental clarity." I know
that word comes up over and over and over.
And they weren't even necessarily complaining about brain fog.
They didn't say lack of clarity before.
Right. They didn't realize they had lack of clarity.
It's a very important point you're making, and that I think we've made many other times. So much of what we do is trial and error, and we need to be comfortable trying things that might not clearly be indicated based on what we know. So, for example, traction. Another example is no supporting evidence for mast cell activation syndrome, but I think we should try these meds because it may help your brain fog. Bam, it helps. Same with the blood thinning agents or anticoagulation. Maybe you start low, but I've sometimes taken a patient, we're not getting anywhere, let's try Lovenox. Let's do injectable heparin. Definitely risk, could go over the risk, but it's a relatively acceptable risk for a potentially enormous benefit.
Right, I agree.
So important not to insist clinically, this is more directed towards physicians in a sense, not to insist clinically that you have absolute gold standard evidence before you do something in patients that are so desperately suffering.
Right, and again, we do our best to make sure that at the very least the patient is safe, and at the very most the intervention we're recommending has a good chance of having a benefit, right? Because there's a sound theoretical idea about why it should, and based on what we know and what we've seen over the years, and even what some research does tell us, frankly, there is some research out there. What about guanfacine? That was in the news a couple of months ago about brain fog and guanfacine. Do you ever use it?
So I use a lot of guanfacine for POTS, for dysautonomia.
Yeah.
So in effect, I'm already using it. That report was 12 patients, I think, taking guanfacine and NAC.
Right. Guanfacine and NAC.
So I probably had 50 patients contact me after that report came out in the paper.
NAC, of course, is easy for them to take.
Yeah. So, but I can't say that I've seen anything dramatic.
Yeah, I haven't either. And I like NAC. I prefer glutathione, but it's not bioavailable orally. So NAC is its precursor. But we do a lot of glutathione pushes in the clinic with IVs. And people do like glutathione. They do feel that it actually helps their brain fog. I will also say vitamin D intramuscular injections, people tell me that their brain fog seems better after vitamin D. You should try it. It's just an injection in their butt.
So even if they have good level on the supplements?
Oh, yeah. Yeah. Yeah, I'm sort of turning away from a lot of oral supplements if I can. I just want it to have more of a direct effect, and I find that having to go through the stomach and through first pass metabolism and who knows what's in there, not only the excipients, but what after metabolism, what ends up being more bioavailable. I feel like I don't have, to sort of make conclusions as to what particular supplemental plan is helpful. I just feel like it's not consistent across patients because everyone's got different microbiome and different gut issues. And so I'm trying to have more direct administration of phytonutrients and vitamins that I know are helpful, that we'll all agree, but administered in a way where it's much more direct, that I could say cause and effect a lot more conclusively, which I know is still not conclusive, but more so than I think oral administration.
When you talked earlier about using more blood thinners, anticoagulation, what are you using?
I use Plavix and aspirin.
Yeah. Okay.
Yeah. And we do dual therapy a lot for a month or so after like a stroke, for example. And then we drop one.
Okay.
So
other causes of brain fog, which we probably won't get into now, but we've talked about separately, are sleep disorder, lack of sleep, or poor sleep is probably a better way to say it. Obviously, fatigue. We should say something about mycotoxin, mold mycotoxin illness. It's continues to surprise me the number of patients who will say, I live here, I have brain fog, I took a trip to Hawaii, my brain fog disappeared, I came home, I had brain fog. It's like, that convinced me. Initially, I was a little skeptical in the mycotoxin world, but I am totally on board with it.
Yeah, no, me too. I think that there are so many exposures that just result in brain fog. And worse, frankly, I mean, I've had in the past couple of months, several encephalopathic patients who have, rage episodes or episodes of what seems like delusional, dementia, but then they get better. So it's not a
Hmm.
progressive process necessarily, but these episodic, almost psychosis, so there's something called post-ictal psychosis, which is if you have seizures, then you have a psychosis directly after. And I always sort of say that there are patients that have spent a good portion of their lives in psychiatric wards that have probably were just having seizure disorders. But so I always sort of think about whenever I hear that kind of description, I get EEGs, and a couple of times I actually have found that there were subclinical events going on that no one picked up on because everyone just assumes that a seizure is obvious and
Right.
visual, and it's not
So
always the case.
And those more severe patients, they're not our typical brain fog patients.
No, they're not a typical brain fog, that's for sure. But I'm saying it could, depending upon what the exposure was, because you brought up mycotoxins, for example, because there are other exposures that can do it. It could be a lot worse than brain fog if you don't remove yourself from the exposure,
Right.
or if you don't treat the exposure.
Right. So in those patients and in many of the other patients, I think it's important to consider infection cause. Tick-borne disease, especially Bartonella and Lyme, well proven to cause this. I've literally taken care of families where the multiple people have Bartonella and they all have dementing-like illnesses.
Yeah.
Lyme is well proven to do it. Mycotoxin, as we said. EBV reactivation, that causes autoimmune. It causes everything. And it's very common.
Yeah.
So, infection needs to be strongly considered.
I mean, so if you successfully treat the infection, does the brain fog improve?
In the examples I just gave, yes. Not so easy always to treat, but yes.
Right. That's where I was going with it. So, I feel like we're going to go back to an infectious podcast now. But, so what is your first line treatment for EBV, for example, if you find that it's been reactivated and now there's brain fog?
I still usually start with Valtrex or Famvir, even though that is not well proven to be active against EBV. It often works and it suppresses it. It can't kill it. We don't have any drugs to kill EBV.
Okay.
But it can suppress it, put it back into a latent state. And if it doesn't, I'll go to Valsite, valganciclovir. And lately I've been using an old HIV drug, tenofovir, which Bella, my partner, told me about. I had not seen that literature, that it has efficacy for EBV. It's way less side effects than Valsite. So I've been using more and more of that.
Is it approved by insurance for EBV?
No, but it's generic, so it costs nothing.
So it's cheap.
Yeah.
And then what about...
I can't believe how old that makes me. But
And then what about Bartonella and babesiosis and Lyme?
Yeah, it's so complicated. I'm not sure. Antibiotics, oral, sometimes IV. I have a physician patient who had terrible cognitive impairment, really terrible, and on IV antibiotics dramatically improved. He is by no means cured, and we stopped it, and now he's recurring. But the moral of that short story is that on IV antibiotics, he really got better. And that's particularly true for Lyme, I think, as well. Yeah, Lyme is it can be a neurotropic bacteria. One of the in the early days of Lyme, one of the classic presentations was acute Bell's palsy. So, we need the intravenous doses to get into the brain.
Right.
But it's a complicated
And the reason
process.
behind why it recurs when you stop the antibiotics, is it just because the Lyme is just this hardy bug that...
I think it's because it can do what so many bacteria do, which is it's like the bacterial version of cell danger response. They go into a latent hibernating state. They drop their metabolic rate.
Because the danger is the antibiotic.
Right.
Got it.
Antibiotics become useless. So those are the so-called latent or persister organisms. And, that's why there's been discussions of using medications like disulfiram and methylene blue, which look effective against the latent organisms. But it's difficult and frustrating because of that. And for the same reason, although mainstream ID, infectious disease, does not recognize this, as far as I know, the tick-borne infections can be latent and reactivate in exactly the same way as EBV. So they need treatment.
Yeah. Yeah, I often see patients who will tell me that they felt great while on antibiotics, but then the minute they come off, they just relapse. Right. And I don't know where to go with that. Like, so do you put them back on antibiotics? Knowing
I think you do, or recently what I'm doing a little more of is alternating or pulsing different, like a month of this and then change to a month of that. The other piece, as always, is you need, or it's better to have a very competent immune system to fight any infection, particularly these guys. So anything I can do to augment their immune system. My go-to was thymosin alpha-1. Thank you, FDA. I can't get that anymore. Exosomes, I think, are another reason to use exosomes is that it can augment and balance the immune system. But it's challenging, for sure.
Yeah. So I just sort of take it as from an immune approach. I try a bunch of immunomodulators.
Yeah. I mean, definitely do that too, for sure.
Anyway, so back to brain fog.
Yeah, sorry about that.
I was curious because I just saw a couple of patients who had that kind of story. You know, they have Lyme and Bartonella, felt great on IV antibiotics, but had been on it for years, and then they came off of it, and then they just feel...
It's a very frequent, common story. And again, mainstream medicine, unfortunately, does roll their eyes at that. They don't believe that story.
I know they don't,
but it's true.
Such a shame.
It's there.
Yeah, they don't... Well, a lot of mainstream medicine doesn't believe in chronic Lyme.
Right.
So that's a problem to begin with. Much less the treatment of it. So brain fog. So that's generally what I do. I'm fairly aggressive at it because that's no way to live, right?
That's horrible.
You can't like live in a fog. You can't work in a fog. You can't engage with your family in a fog. You can't do anything in a fog. So you have to be able to have some semblance of cognitive function and cognitive control. And cognitive fatigue is worse because then you feel like you have to reserve your energy. And how do you know where to apply that energy, right? I mean, are you going to read a book? Are you going to have a conversation with your partner? Are you going to play with your kids? You know, so... the whole goal, of course, is to increase quality of life for patients.
And it's the reason, in terms of septat stuff, it's the reason I torture my patients with frequent, repeated Nasoline tests, because my argument is if we can't perfuse your brain, you're not going to get better.
Right.
And I can't know unless I see the results of that test. I can't know how to titrate your dose, how to tweak the dose. Should I change the medicine? Should we add a third one or a fourth one without seeing those numbers? And the same goes with the leaky gut. I mean, there's a part of me that's beginning to think, why am I testing every patient for SIBO? They all have SIBO and they all have leaky gut. But I'm still like to document.
So you still do tests for SIBO on everyone.
I do.
See, you don't do the skin biopsy for sulfur neuropathy, but...
Well, my argument is sometimes they only have hydrogen positive, not methane, and then the treatment's a little bit different. And I do like to get serial follow-up testing.
Right.
Because that's curable. I don't know how to cure small fiber neuropathy.
So when someone has SIBO, we're way off topic. When someone has SIBO, do you test like you test anyway vitamin deficiencies?
I do,
yeah. Because I'm always worried about sort of the malabsorption and then
Sure.
Yeah. Because that can contribute to brain fog.
Yeah.
Yeah.
Yeah. I think that's the message here. It's multifactorial.
Yeah.
Everything it can play into it. And again, it's the reason I love the concept of septat. I know I make too much of it, but I just think
I don't think we make too much of it.
Helps explain to patients so much.
Yeah, I have a good chart on the septat that actually a patient helped me do. Like it's a one-page slide. It's a picture.
Send it.
I will. I'm going to send it to you. But I tried to outline not only the septat, which we all know very well at this point, but sort of the consequences of it.
I want to see it.
Yeah, I'll send it to you actually, and I have to give credit to the patient that helped me do it.
That's what we should put on our Patreon.
That's right. Ooh, that's a really good idea. Yeah, it's a really good idea.
Yeah, that'd be great.
Yeah, we should actually have a patient come on our podcast and interview a patient.
Yeah, for sure.
Yeah,
for sure.
That's be.
What about red lights? Do you use that? Do you find any benefit of that for brain fog?
I don't use it regularly enough. I know patients who have them in their homes and they've purchased them and they really report great benefit for sure.
Yeah.
Yeah.
Yeah, I know I've had other patients and some clinicians report that as well.
I like HBOT a lot for brain fog.
Right.
Perfusion, it's all about perfusion. I will prescribe them hyperbaric oxygen therapy treatments if they could find it in their area, which is sometimes the hard thing to do. And oftentimes it's not covered by insurance, and patients try to get it covered because those sessions can be expensive, and you actually need quite a few of them.
Right.
So it's not like a one and done, unfortunately.
And these are real. This is HBOT with a hard shell.
With a hard shell, yeah. And you need, I would say at the very minimum 20, but usually it's around 40 is when you really start to feel the benefits. So it can get very costly. So I do recommend it because I find that it's very effective at any kind of cognitive fatigue. It just gives the mitochondria a little bit more oxygen to work with to produce more energy. Because of the force, it provides the force for perfusion. So I like the HBOT.
So I've also found Celebrex to be very helpful,
Mm-hmm.
which is interesting. It's
Yeah.
just an NSAID. It's just ibuprofen, fancy ibuprofen, but it actually works way better.
Right. Well, it reduces some of the inflammatory mediators.
That, and I think it is a mast cell inhibitor, and it's
Mm-hmm.
working in multiple ways. I think in I don't do molecular Cunningham panel on every patient, but I think if I have a patient who's really impaired, I will always do it, because that will, if positive, shows us that this is autoimmune driven or
Mm-hmm.
partly autoimmune driven, and also then moves the thinking over to things like IVIG, plasmapheresis.
Yeah, for sure.
Any potent immune modulating therapy.
Yeah, I don't do the Cunninghams as often for brain fog specifically, though I'm now thinking that maybe I should. I think of it when there's also any kind of certainly the like the rage episodes that I already mentioned. I will definitely think of the Cunningham's panel for those patients. But if there's any kind of abnormal movement that developed at some point, during the course of their illness, I'll think more about the Cunningham's panel.
Yeah, it's also based on history. So I have a lot. I'm sure you have the same thing. I have a lot of patients who say, "Oh, I was fine until I got COVID," or "I was
Right.
fine until I got mono at 24 years old." But when you take their history from 2 to 12, they had frequent otitis, frequent ear infections, frequent strep infections. They developed some funny OCD stuff, doc.
Yeah.
I don't know why, but I suddenly was, I had to touch the wall 4 times before I go out, and
Yeah.
real OCD stuff. Those are patients that likely do have a positive Cunningham panel
agree.
and a PANS-like illness. The fact that they then went on with their life and were okay until they had their so-called precipitating event doesn't mean they didn't have stuff cooking all that time beforehand.
I 100% agree. Yeah, I always find little pearls in their history well before they thought they were sick.
Oh, yeah.
Yeah.
I mean, we'll get into this when we do long COVID, which I assume we'll do, but I was just telling
We will
somebody yesterday, I can't remember who it was. I have not yet met a long COVID patient who they say, I was fine till I got COVID, and then when I take the history, they absolutely, unequivocally have or had a degree of mast cell activation syndrome, dysautonomia, etc. It's amazing.
It's so prevalent, and I think that that's actually one of its problems is that, take allergies, for example, like the atopia, as we learned at the triad, like the eczema, allergies, and asthma. It's so prevalent in the society, and I think that has worked against these patients because, allergists and immunologists would go like, oh, who doesn't have that?
Right.
Who's not allergic?
So you have a milk allergy, so you have rashes. I mean, what's the big deal? And in fairness to those doctors, if you're a kid and it's not impairing you or making you less functional, no big deal. But later on, when they get their COVID or their Lyme disease or their EBV or their mono, that kicks that, now we understand, mast cell activation syndrome into major high gear, and the horses are off and running and the septet doors are opening.
Right. No, absolutely. So it's like a prelude. Right. So, and it's a buildup, and it's scary because then you worry about, what if I get bit by a tick now? So you have to worry about the next event in your life that might sort of send you off that cliff, and where you were functioning all along, now all of a sudden you're not functioning.
Yeah.
And
have you had any long COVID patients who truly had no prior history?
No.
Yeah, I haven't either.
Not a single one. It might have been a mild history, but it's a history nonetheless.
It's a history. There's something there.
There's something there.
And I don't think we're making it up. I'm not over, not doing the hammer nail thing. I think that there really is something there.
I completely agree.
Yeah.
I always worry about that too. Am I making too big of a deal over the fact that you had a couple of ear infections when you were young? Because, as you know, any pediatrician will say, "Oh, every kid gets ear infections."
Right.
And to some extent, I suppose that's true. But then I think about sort of that one-hit, two-hit theory. The hypothesis in medicine, right? So why can't this just be sort of in that line where the first hit was that you had a couple of infections and you had a couple of rounds of antibiotics, and then somewhere you were in high school you got mononucleosis.
Yeah.
And then you traveled in your 20s and had some severe gastrointestinal illness.
One of my favorites is the gastro. Like I had a lot of patients this week. Another patient this week who basically in the course of the history traveled all over India and Asia and stuff and described at least 7 or 8 gastroenteritis episodes, right? Before she was sick, of course. Before she had long COVID. No big deal.
I got better,
Well, come on.
say.
Basically, in my mind, that patient had SIBO and leaky gut from, I think it was 8 years old was the first one, right? So at 25, that's 20 years of leaky gut chipping away at parts of their body.
That's right, including the brain.
Yeah.
And right, exactly. And that's why brain fog
Yeah.
develops.
I think the one hit, two hit concept is very important.
Yeah. And that's how I always think of it. And so to just sort of say, well, every kid gets, ear infections, I think is sort of missing the point. It's not that I'm arguing that. I think to some extent that's true.
It's true. But not every kid gets ear infections and then has OCD-like symptoms and then suddenly isn't doing as well at school.
Right, and that's what PANDAS is about, right? Not everyone, everyone gets strep throats for the most part. But not everyone wakes up the next morning and is afraid to get on the school bus.
Exactly.
Right. So I do think that we have to recognize, and maybe that comes into the idea of what genetic variants you hold that just make you more vulnerable or more susceptible to this kind of immune response to an organism or a pathogen of any sort. Yeah. And so that's why I do a lot of genetic workup, actually, because I try to find those variants. Like, so what made you so special that your body couldn't handle this particular infection, that it sort of went awry, right? So I try to find those variants, and I don't know what that variant is that I'm looking for technically, but I try to sort of see what variants you hold.
But I think you can also find it again from history taking. If you take a family history and there's a strong history of autoimmunity in the family, my uncle had rheumatoid arthritis, my grandma had Sjogren's disease, and somebody else had rheumatoid, and somebody had just arthritis, and then I had one celiac patient in the family. I mean, come on.
Yeah.
There's a lot of genetic noise stuff.
Right.
And that vastly increases the concern.
Right, but you're not looking for what variant they may hold.
Right. No, I'm not. I mean, I can do that too.
No, I know. That's what I'm saying. So
I
think
do.
it's important.
I do. But I have to say, I feel pretty ignorant about that. I look, but I'm not sure what to do when I find these variants. That's a whole other topic with channelopathy and Dr. Bowles and everything else. And it's pretty overwhelming.
Right. It doesn't have to be overwhelming, though, right?
No, it's just another thing I got to learn more about.
That's what we do. I mean,
that's a perfect example of the scribe idea that I talked about before.
Exactly.
And I have a list on my desk area, which is, if I sound disorganized on these podcasts, you should see what my desk looks like. Stickies all over.
Well, you already told me you have like 50 tabs open on your laptop.
And like stickies all along here. So one of the stickies is a collection of the most common variants I'm seeing in patients, but I've yet to figure out how I'm going to approach figuring out what that means. So I think we're incapable of staying on topic.
We are incapable. But again, these are our conversations. Right. I do want to talk about genetics one day, because I think it's fascinating what I learn, because I do go searching, and then I find these variants, and then I spend some time looking up these variants, and then I apply it to this particular patient, about the history that I know, and the response to treatment that I've offered, and just the symptoms that they have. And I'm amazed at how it changes like my entire approach to this particular patient. Not overall, but to this person sitting in front of me or on the video.
No, I would like to have that episode, that conversation.
Yeah, that would be a good episode.
Yeah, I need
All right,
to learn
awesome.
more.
I think we're out of time.
Darn. Okay. Well, I hope we cleared up that fog.
I think we made it foggier. I hope not, actually, because we do clearly have an approach to brain fog that I think can be very helpful. Right. And we'll just continue to learn more about it and tweak our plans.
Right.
Yeah.
So thank you.
Yeah, thank you.
Please send us your questions. Please let your friends know about this.
Please let us know what topics you wanted to discuss, because we can discuss anything on this planet.
See if you can get your doctors to watch. We're really trying to grow this. The people that watch tell us they love it, but not enough of people are watching. So, thank you.
You're impatient. It'll happen over time.
I am impatient.
I have faith. I have faith in you guys out there.
All right. Thank you very much.
All right. Have a great day. Bye.